Good morning. This is a short video to explain the fundamental concepts of the ECG or the electrocardiogram. Of course, the suffix gram means recording or tracing, and cardio means heart, and electro means electric activity. So actually, the electrocardiogram is a device that is used to record the electrical activity of the heart. And you obtain that that recording of the electrical activity in the form of a strip of paper. And on that strip of paper, you can see the different waves of the tracing of the electrocardiogram being repeated. From the electrocardiogram, we can have several diagnostic tools or achieve several diagnostic purposes, but we have to say first that the ECG or electrocardiogram or EKG, like we call it in the States, is a very useful tool because it is a cheap tool. It is a portable tool. It's affordable. The price is affordable by most of the patients. It's very informative because it gives you a lot of information, and you have a recorded tracing. So it helps you record the medical status of the patient. And furthermore, it's painless. And that's why it is a common tool in diagnosis in medicine. So as we said before, the main purpose of the electrocardiogram is to record the electrical activity of the heart. And as we said previously, if the patient is lying down like this, and if this is the position of the heart while the patient is lying down, and if you put here the various electrodes that are attached to cables and to the ECG device, it's possible to record the electrical activity of the heart. I mean, the different waves of depolarization and repolarization of the heart, just because there is fluid inside the body, whether we are talking about the extracellular fluid around the different cells, or the pericardial fluid, of course, that is around the heart, or even the blood vessels, the blood inside the vessels. So the presence of liquids or fluids inside the body that are full of electrolytes or ionic compounds like sodium chloride, for example. Electrolytes, these are ions that are capable of transferring the electrical activity. So it is possible to record, to have a very important view of what's going on inside the heart. And we will be seeing on the next slides that we have 12 perspectives or 12 views of the heart. So you can visualize the electric activity of the heart by visualizing 12 sides of the heart, or by visualizing the electrical activity of the heart from 12 perspectives. And therefore, we use 12 leads or 12 cables of electricity, as we will be seeing on the next slides, in order to record the electrical activity of the heart. The electrocardiogram is important in four actually important diagnoses. The first one is whenever you have an abnormal heart rate or an arrhythmia, whether it is a tachycardia, which is a rapid heart rate, or a bradycardia, which is a slow heart rate, or an irregular heart rhythm. But it is also important for detecting insufficiency of blood supply to the myocardium that is most probably manifested on the patient as chest pain, which we call cardiac pain. So it is also very useful in detecting ischemias, and it is also used to detect enlargement of the chambers, because sometimes when, for example, you have left ventricular failure or right ventricular failure, when the ventricles fail and are no more capable of contracting, they enlarge in size because contraction shortens the muscles. And when contraction shortens the muscles, it narrows the cavities. So when the heart is capable of contracting adequately, it will have a smaller size than when it is relaxed or dilated. And if it is failing, the dilatation is more and more, as we might be seeing later on over the slides. The last item that can be detected by the electrocardiogram is the conduction defects. What do we mean by conduction defects? We all know that we have two types of conduction. This conduction of electric impulses that occurs over the whole myocardium from the SA node over the atria and from the atrioventricular node over the ventricles, but there is a very specific type of conduction that occurs at the area of the atrioventricular node. And in such a case, this is an AV nodal conduction defect, which is very important and which is very liable, by the way, to occur in the atrioventricular node, whose main function is to conduct with a delay. I've added 3 slides. Of course, the addition of those slides will change the numbering of the slides, and that's why I'll be adding or uploading the new version or the modified version on Google Classroom. Actually, we use 12 leads to record the electrical activity of the heart, and this is very important because this allows you better and more accurate and more detailed information, more detailed, more accurate information about the electrical activity of the heart when you see it from different perspectives. Of course, the heart does not have 12 surfaces, but we're going to rotate around the heart. Of course, the leads are fixed, but I mean the ECG helps you to see the electrical activity of the heart from 12 perspectives, as if you were rotating around the heart. But if we have 12 cables to record the electrical activity of the heart, we only have 10 electrodes. And at 10 electrodes, the electrodes are those sticky pads that we adjust to the chest and to the limbs. Here, you can just see the chest electrodes. So here you can just see the 6 chest electrodes. But there are also 4 other limb electrodes that are attached to the right arm, to the left arm, to the right leg, and to the left leg. But they are not visible here. They'll be visible on another diagram. And why do we say that the electrodes are sticky pads? Because they're actually sticky. You needn't put much effort to stick them to the body, because they have like they are made of rubber from below, and they have like a vacuum. They create like a vacuum underneath in order to pull the skin upward and therefore stick to the skin. And what is an electrode? An electrode is a conductor device that allows the transmission of the electric activity from the body to the cables. And all these 12 leads will be connected to the recording machine, which is, by the way, a relatively small machine having adjustable buttons. And by the way, the electrocardiogram can be managed by a technician, just like it can be managed and it is recorded by a technician, but it is read by a medical doctor. But in case, for example, of ultrasound on the heart or the echocardiogram, the technicians do not interfere. It is the medical doctor and the specialized medical doctor that is specialized in echocardiography that records the echocardiogram, the ultrasound, and reads it. Or that like makes the machine function, because actually in the ECG, you visualize it on a screen. You might record pictures or not, but you visualize it on a screen. Where are the remaining electrodes? The remaining electrodes are put on the arms, as you can see here in this diagram. So we have the right arm, the left arm, the right leg, and the left leg. So here you have 4 cables that arise from each of the limb electrodes, and arising from the 6 chest electrodes, we have 6 cables, and there are 2 additional cables. But we are not going to go into the details of the cables and why they're 12 and not 10, but we can here, what's important is the positioning of the chest electrodes. So here you can see, I'm just checking if there is a repeated diagram. Here you can see that we adjust the V5 electrode just at the apex in the 5th intercostal space. You needn't know, it's not like the auscultatory areas, you needn't know them by heart, but you can see that V4 is internal to V5, but at the same level in the 5th intercostal space, and then you have V3, V2, and V1 are opposite to each other. I'll never ask you about the detailed spaces where you adjust the electrodes. And now we can see the tracing that is obtained by a normal ECG. And you can see that that tracing will be repeated. So this is a whole cardiac cycle. The tracing you see here is a whole cardiac cycle. And then it will be repeated afterwards. So if the strip is long, and it's usually the case, you will see another P wave and then another QRS complex and so on. But what's important to know is that when you obtain the strips of ECG, you will find under a group of tracing lead 1. This means that the technician has started by lead 1, and then after a while we stop the button for lead 1 and we start lead 2 and so on, and then lead 3. And then afterward, we will find lead V1, V2, V3, V4, V5, V6. You will see the same tracings, by the way, but more or less different, meaning that in some tracing, like lead 3, you will not find, for example, a tall QRS complex. You will find a different shape for the QRS complex. And because the perspectives of the leads are different, whether we are talking about the limb leads or we are talking about the chest leads. That's why at the level of human biology, the undergraduate level, grades 11 and 12, we will only be focusing about the tracing that we can see on lead 1. So all the specific shapes that will be described here are those of lead 1, which is the first one we learn when we start learning ECG. We have a P wave, we have a QRS complex that consists of 3 waves, and that's why it is called a complex. And the QRS complex starts by a small negative wave or a small negative deflection that is called the Q wave. And then you have a tall peaked R wave. And then you have another negative deflection, that is the S wave. And then you have another upright wave like the P wave, but that is a bit taller, called the T wave, and more or less symmetric, because the P wave is not exactly symmetric, meaning that the peak of the P wave is not exactly at the middle of the P wave. So we saw the waves. We have four waves: P wave, Q wave, S wave, and R wave. But two of those waves form with the fifth wave, which is the R wave, the QRS complex. But this is not all what we see on the normal ECG tracing. We can also see the PR segment. As you can see, the PR segment starts at the end of the P wave and ends at the beginning of the Q wave. So this is the first interval. It is the distance between two successive waves. And we have another interval that is called the ST wave. Of course, you might be wondering why this is not called a PQ segment, because it ends at the Q wave, but because there is another thing called interval that is called the QT interval here, and that's why, in order not to mix up things. So the PR segment, the nomenclature is a bit confusing because it starts at the end of the P wave and begins at the it starts at the end of the P wave and ends at the beginning of the Q wave. Another segment between two successive waves, that is called the ST segment, and that one sounds logical. The nomenclature sounds logical because it starts at the end of the S wave and ends at the beginning of the T wave. But in addition to those T segments, which are the PR and the ST segments, we have the intervals. What's the difference between an interval and a segment? A segment, as we said, is the distance between two successive waves, but the interval is nothing but a wave plus an interval. Plus a segment. I'm sorry. So it is a segment. So what is an interval? The interval is a wave plus a segment. Of course, this axis is the axis of time. So when we say PR interval, we are interested about the duration of the PR interval. And the QT interval starts at the beginning of the Q wave and ends at the end of the T wave. It is another interval that we can see. So because the horizontal axis is the time axis, so the importance of the intervals as well as that of the segments is in their duration. Are they within their normal duration, or are they shorter in duration or longer in duration? And both the diminution in the normal duration and the increase in duration, so the diminution below the normal duration and the elongation beyond the normal duration, both are indicative of a possible disease. So it's not about being longer only or about being shorter only. Both are abnormal. What makes us call this interval of time a PR interval? Because it consists of a wave, which is the P wave, as well as an interval, as well as a segment, which is the PR segment. And what makes us call this a QT interval is that it consists of a segment, the ST segment, in addition to not only one wave, but four waves. We have the Q wave, we have the S wave, as well as the R wave. So these are the normal ECG components seen on a normal tracing of ECG, but again, I emphasize that they are seen from the perspective of lead one. How are the ECG waves connected to the cardiac cycle and to the heart sounds? So here we have, this is an ECG, but this is a recording of the um, the heart sounds, as this is an audiogram. This is not a tracing of the electrical activity of the heart. This is an audiocardiogram where you can listen to the heart sounds and you can see the intensity. I forgot to tell you that in the normal tracing, the horizontal axis represents time, but the vertical axis represents the voltage. So what is the amplitude? I mean the voltage. So this is the voltage on the y axis, of course, in millivolts, the potential difference. And the voltage will definitely affect the amplitude of the wave. So when there is the highest voltage difference, we get the highest amplitude, and this is definitely the R wave. And you can expect, of course, and anticipate that the R wave, or the QRS complex as a whole, represents the wave of depolarization over the ventricles, as we will be seeing later on, because of course the ventricles have the thickest muscles, the ventricles together. And when we say that the QRS complex represents the spread of, the QRS complex represents the spread of depolarization over the ventricles, we mean both ventricles. We mean the right ventricle and the left ventricle alone. Together. So here, how can we synchronize the two, or how can we analyze the chronological or the time relationship between the electrocardiogram, which is a recording of the electrical activity of the heart as a whole, and the heart sounds, which are a recording of the activity of the valves? Because S1 here is a recording of the sound that is obtained by closure of the atrioventricular valves, whereas the S2 sound is due to the closure of the semilunar valves, which are the aortic valve and the pulmonary valve. So here you have a tracing on paper. You don't hear anything. You are recording the electrical activity, and you finally obtain a tracing on paper, a tracing on a strip of paper, on an ECG strip. But in the heart sounds, in the audiocardiogram, you hear sounds. So it's an audio. And you hear sounds that are not related to the, here, the ECG represents the electrical activity of the heart as a whole. You're talking about the whole heart. You're following the atria and then the ventricles and then the repolarization of the ventricles. But here, you're focusing only in that heart. You're not supposed to hear any sounds other than S1 and S2. If you hear any sound in between, then it would be an abnormal sound superimposed on S1 and S2, and it would be called a murmur, as we will be seeing later on. So what is a murmur? A murmur is an abnormal sound that is superimposed on S1 and S2, whether this murmur lies after S2 or between S1 and S2 or just before S1. In all cases, it's an abnormal murmur. It's an abnormal sound superimposed on S1 and S2, because you're not supposed to hear any sound other than S1 and S2. And now we come to the synchronization. How are they really synchronized or not? So you can see here that S1 occurs when closure of the atrioventricular valve, closure of the tricuspid and the mitral valve, which are the atrioventricular valves, tricuspid valve and mitral valve. When does this occur? It occurs at the start of, or at the beginning of, ventricular systole, when the ventricles start contraction. And this is exactly matching with the QRS complex, because what does the QRS complex represent, as we have seen on the very difficult diagram, but very useful diagram that we saw before about the cardiac cycle, we saw that the QRS complex that represents spread of depolarization over over the ventricles, spread of depolarization over the ventricles. Once there is spread of electricity over the ventricles, they will start contracting. And this is what exactly happens. A fraction of a second afterward, the ventricles start to contract systole and the valves start to close and we start to see S1. I would rather say that S1 tracing should be a bit to the right. They're not exactly under each other because, and actually they are, because here the diagram is correct, because here, where is the peak of R? The peak of R is here, but the peak time for S1 is here. So it's a fraction of a second afterward. Similarly, S2 occurs when? S2 is the closure of the semi-lunar valves. The semi-lunar valves start closure when at the start of diastole, when the ventricles relax. So it's very logical that S2 comes just after T, because T represents what? T represents the recording of repolarization, or the spread of repolarization over the myocardium. And spreading repolarization over the myocardium means that we have adjusted the electrical gradient, we have adjusted the chemical gradient, we have returned sodium to the outside, we have returned potassium to the inside, and now we are again in the polarized state, or in the resting state. And that's why, and this matches exactly with the start of diastole. So again, this is just a recapitulation. We have the P wave, and the P, this is the first time we define what the P wave represents. So the P wave is a recording or a tracing that records the spread of atrial, I would rather say spread of atrial depolarization, or the spread of the wave of depolarization over the atria. The QRS complex as a whole represents the spread of the wave of depolarization over the ventricles. The T wave represents ventricular repolarization, or again, the spread. We understand it more. That's why I'm insisting on saying spread of the wave of, because it's more understandable when we say that the T wave, for example, represents spread of the wave of repolarization over the ventricle, and sometimes there is a very small U wave after the T wave. We don't see it frequently, and scientists or medical doctors do not know until now what this wave represents. And now let's see, how can we visualize a normal sinus rhythm? A normal sinus rhythm means what? A normal sinus rhythm means that this ECG tracing, this lead one of the ECG tracing, represents the electrical activity of the heart when the SA node is the pacemaker. And not only this, but when the SA node pacemaker is normal. So because the SA node might be diseased. And sometimes we have tachycardia that originates from the sinoatrial node. In such a case, we would call it a sinus tachycardia, meaning increased heart rate. So is it a normal heart rate? No, it is a heart rate that is higher than 90, that is higher than the upper normal range, but it is still arising from the sinoatrial node. So it's not only important to say sinus rhythm, but if you are talking about a, a really normal sinus rhythm, a really normal rhythm arising from the SA node. So it's not enough to say sinus rhythm, but normal sinus rhythm, because there are other abnormal sinus rhythms. What are the criteria for a normal sinus rhythm? The criteria are deducible, easily deducible, when we remind ourselves that it arises from the SA node. So if it arises from the SA node and the SA node is normal, so first of all, it has to beat at a rate of 60 to 90 times per minute, 90 beats per minute. So the rate should be 60 to 90 beats per minute. And then the rate should be regular. So the second condition is that we have a regular rhythm. The third condition is that if it is really arising from the sinoatrial node and spreading normally from above downward to the AV node and then spread across the AV node to the two ventricles, then the wave of depolarization of the ventricles should come after the wave of depolarization of the atria, and therefore the QRS complex should come after the P wave. And this is what we see here. This is the P wave, and then this is the QRS complex. Again, when this is repeat, and this is of course the T wave, and then we have a P wave, a QRS complex, and then again a T wave. So every time the P wave precedes the QRS complex. You might be asking yourselves, so is it possible that the QRS complex comes before the the P wave? Yes, it is possible, but it is rare. Why? Because in order for the QRS complex to come first, this means that there is a complete dissociation between the electrical activity of the atria and the ventricles. They are not following the regular pathway. They are completely dissociated from each other. And this occurs in severe arrhythmias or abnormalities of the heartbeat, which we'll be studying later on over the week, inshallah. Another thing is that if it really arises from the SA node, then it should have traveled normally through the AV node. And if we tell you that the PR interval, let's go back to the PR interval. The PR interval, not the PR segment, it represents what? It includes the P wave and the PR segment. So the PR interval includes actually what? It includes the spread of depolarization over the atria. And afterward, it includes the conduction from the atria to the ventricles, because the QRS complex would have never started if the electrical activity hasn't been conducted. So actually this part, which is the PR segment, reflects the function of the AV node. Did the AV node conduct the electricity from the atria to the ventricles in the normal period of time or not? So the PR interval represents what? The PR interval represents or reflects the conductivity across the AV node, or simply it represents AV nodal conduction. Does it conduct at the required speed, which is already delayed, or not? The normal for the PR interval is that its duration should be between 0.12 seconds to 0.20 seconds. And it should be constant, meaning that, of course, here the PR interval is very small, but because the ECG strip image is small. But here, if you look here, at the PR interval, say that the PR interval here is 0.12, which is the minimum normal. Then if I continue the tracing, then there will be a P wave and another PR interval that should also be 0.12. So for the PR interval, there are two conditions, not only one condition. The first condition is the duration that should lie between 0.12 to 0.20 seconds. 0.20 seconds is 1/5 of a second, and it should be regular. It should be equal in throughout the whole tracing, meaning that there is no change in the activity of the AV node from one cardiac cycle to another. The QRS complexes should all look the same. So how can I, as a beginner, know that they look the same? First of all, they should have a Q, negative deflection, and then an R, and then an S deflection. But furthermore, the duration, they should be as narrow as the ones you see here. Mine is broad, the one I've drawn on on the screen, but they should be narrow, as you see, because the duration of the QRS complex as a whole should not exceed 0.12 second. You imagine it's the whole QRS complex, not only the R wave. So this duration should not exceed 0.12. It should be less than 0.12, which means that the R wave should be narrow, tall, and peaked, as you can see. You needn't know the duration, but of course, there are certain conditions when the Q waves are shorter or longer, but this is outside the scope of the curriculum. Furthermore, the QT interval, and the QT interval is of extreme importance. It begins at the beginning of the Q wave and ends at the end of the T wave, and it shouldn't be more than 0.44 seconds. Is it important to know this value? Yes, extremely important. Is it important to calculate it on the ECG tracing? Yes, it is extremely important. So it shouldn't exceed 0.44 seconds. Why? Because there are certain people who are born with a long QT interval. So this is a congenital disease where the individuals are um, born with. But there are cases where the patient might have acquired QT, a prolonged QT interval, as a side effect of certain medications. What's the drawback of having a a longer than usual QT interval? This is a threat to the patient. Why is it a threat to the patient? Because it might result in fatal ventricular arrhythmias. And this is all what you have to know at this level about a prolonged QT interval. You have to know the normal value. You have to know what a long QT interval is. You have to know that it might be congenital or acquired, and that it is threatening to the patient because it might lead to a fatal ventricular arrhythmia. After having said this, there remains one important thing. How can we calculate the rate? Of course, you might have noticed that the ECG strips are lined. There are squares like the graph paper, and this helps you a lot to calculate the rate in the ECG strip. We have several ways of calculating the ECG strip when the heart rate is regular. When the heart rate is regular, you can divide. This is in order to calculate the heart rate, how many beats per minute. You can divide 300 by the number of big boxes, in between two successive R waves. Like here, for example, here, of course, this is not the same ECG strip. These are parts of ECG strips. One is detached from one strip, two is detached from another strip, because you can't have an ECG strip with increased length or gradually increasing RR intervals in a normal individual. The RR interval is the duration of time or the distance or the number of squares between two successive R peaks. So the pink one or purple one is taken from an ECG. The green one is taken from another ECG. The orange one is taken from a third ECG, to show you different examples. So here, let's start by the yellow one. Here we have 5 big boxes. It happened that we have 5 big boxes between the R intervals. 1, 2, 3, 4, 5. So the heart rate in that ECG strip is 300 multiplied by the number of R interval, but in large squares. So how many large squares or big boxes do we have? We have 5. So the heart rate is 60 beats per minute. Obviously, the heart rate here in the yellow ECG strip has been calculated to be 60 beats per minute. But if we calculate that one, you will be dividing the same numerator, the same fixed value by 1, 2, 3, 4 big squares. 300 divided by 4 equals 75. So here the heart rate is 75 beats per minute. And it's obvious because the smaller the RR interval, the more frequent the QRS complexes, and the higher, of course, the number of beats per minute. Here you have only 3 large squares, so the rate is 300 over 3 or 100. Of course, the narrower the RR interval is, the higher the heart rate. So as the RR interval diminishes, the heart rate increases. So the relationship between them is an inverse relationship. But sometimes the heart rate is irregular, and in such a case, you might, again, these are different ECGs, but let's imagine that this is one ECG and that the heart rate of the patient is sorry, forget about this, but we can calculate the heart rate in another way, which is to count the number of small squares. So you can use another constant, which is 1000 over 500, and divide it by the number of small boxes in between the RR interval. So you're again dividing, but the RR interval, but because you have used a different constant numerator, you're gonna count the small squares. So, and you will obtain the same value, because here, for example, you have, when you count the small squares, they are 15. So the heart rate is 100 beats per minute. If you use the other method, which is 300, and you divide it by the number of small boxes in between, you will also obtain 100 beats per minute. So whether you are using this method that we said first, or you are using that second method, you will obtain the same value. But coming back to what I said, forget about it. When do we use these methods? We use these methods when the heart rate is a regular heart rate. When it is a regular heart rate first, when it is, so you use those two methods, 300 divided by the number of big boxes between the RR intervals, or 1500 divided by the number of small boxes in between, when the heart rate is a regular heart rate. If the heart rate is irregular, there is another method, but I'll not be saying it now. Maybe we would be saying it in class if we have time. But sometimes now we said that both conditions are used for a regular heart rate. But why would I use this method, which is more difficult, relatively more difficult, and not use this one? Because sometimes the distance between the two peaks of the R waves are not integral boxes. You might have the R complex, the QRS complex, in the middle of a big box. In such a case, it would be extremely difficult to calculate accurately the number of big boxes. So this one is much easier, but it's practical only when the QRS complexes lie exactly on the lines of the big squares. But meaning that you have an integral number of big squares between the QRS complexes. But if you don't find, it might happen that between two QRS complexes, you have an integral number of boxes, and between two other, you don't have. But If you don't have at all any integral number of big boxes, then you must use the other method, which is 1,500 over the number of small boxes. I'll stop here and we'll be continuing next Tuesday in the classroom. Next Tuesday, we will be talking about sinus rhythms, meaning that they arise from the sinoatrial node, but that are not normal. We will be discussing sinus tachycardia, sinus bradycardia, as well as other abnormal rhythms like AF, for example, or atrial fibrillation that do not essentially arise from the SA node. Thank you.